Hello, this is Dr. Nasmani from ACPG Mat. This is the third part of inguinal hernia in children. Hope that you have listened to part 1 and 2. The videos are available in the channel youtube.com/acpgmat, and also the links are available in facebook.com/acpgmat. The links are updated in the channel. In the part 1 and 2, we have been discussing about the introduction, definition, embryology, anatomy, epidemiology, clinical features, differential diagnosis, imaging, and laboratory evaluation. Now, in this third part, we will be discussing about management, postoperative care, complications, and we will summarize it, and also I will give the final references. So let us go to the management of inguinal hernia. The definitive management of inguinal hernia is surgical repair, referral to a surgeon, and timing of the repair depend on whether or not the hernia is reducible or not. In addition, incarcerated hernias must be reduced as quickly as possible to avoid strangulation of the contents of the hernia sac. No mass, reducible mass. If that is the story, a convincing history of intermittent groin swelling or a reducible inguinal mass are indications for referral to a surgeon. Consultation should be obtained promptly, but is not emergent. Once the diagnosis is made, repair should be performed soon to avoid complications such as incarceration. Incarceration has been reported as many as 13% of children awaiting elective repair, the majority of cases in those less than 1 year of age. While awaiting surgical evaluation, caretakers should be informed of the signs and symptoms of incarceration and provided with indication for seeking medical attention. So that is the importance of waiting period. In a case of inguinal hernia, no mass, but it is a reducible mass. Inguinal mass in a female child. Hernia in female are caused by the persistence of the diverticulum of neck and contain the suspensory ligament of the ovary. Up to 20% of these hernias also contain the ovary and sometimes even fallopian tube. Rarely, uterus may also be present. Because of the significant likelihood that reproductive organs are within the hernial sac, clinicians should not attempt manual reduction in female with inguinal hernia and a palpable mass. Ultrasound examination of the hernial sac is helpful in identifying the contents prior to surgery. Incarcerated inguinal hernia. An incarcerated inguinal hernia must be emergently reduced either manually or surgically. Once a diagnosis has been made, children should have nothing by mouth, since emergency surgery may be required to reduce hernia. Manual reduction, unless the child appears extremely ill and has signs of peritonitis, intestinal obstruction, or toxicity from gangrenous bowel, manual reduction should be attempted. Manual reduction is successful in 95 to 100% of the patients. Elective repair after successful manual reduction has a lower complication rate than does emergent operative reduction. Success rate for manual reduction are influenced by the duration of incarceration, age of the child. One report, 85 children younger than 2 years, and those with failed compared with the successful manual reduction were younger, that is 3 versus 5 months, and had longer duration of symptoms, that is 34 versus 12 hours. So the success rate for manual reduction are influenced by the duration of incarceration and age of the child. Survey of the pediatric surgeons revealed that 95% used gentle manipulation to reduce incarcerated hernia. In addition to manipulation, 75% of the surgeons used sedation and 55% of the surgeons used elevation, and less than 20% applied ice packs to the inguinal hernia. This shows how the doctors did the reduction. In the picture, I am showing one technique of manual reduction of an incarcerated inguinal hernia. Reducing an indirect inguinal hernia. The A panel shows anatomy of the indirect inguinal hernia. In the trundle inward position, the patient is kept, and the number B, the gas and stool are first milked out of the bowel to reduce its size. You can see the internal inguinal ring, inguinal canal and external inguinal ring, and evacuation of the contents of the incarcerated inguinal hernia, and how the fingers of the surgeons are directed. And number C, constant pressure is applied for up to 5 minutes from distal to proximal to reduce the hernia. That shows the bimanual reduction. The two hands and fingers of the surgeon are shown. Distal hand applying slightly greater pressure than the proximal hand. So that shows the manual reduction of incarcerated inguinal hernia. The picture is self-explanatory. Pressure is applied along the proximal inguinal canal with one hand, while the other hand attempts to milk the gas or contents out of the incarcerated bowel with gentle pressure for up to 5 minutes. After reducing the contents of the incarcerated bowel, pressure should be slightly increased over the distal aspect of the hernia to reduce the bowel. Alternatively, the doctor can sweep along the inguinal hernia into the scrotum and applies longitudinal tension while providing traction that opens the internal and external hernia rings. The hernia is then walked through the opening. In this, the panel A shows the internal and external inguinal ring and hernia, and then the figure B shows how the hernia is shown, the B, C and D. The arrow shows the various directions in which the pressure is applied by the surgeon. Alternate method for the bimanual reduction of the inguinal hernia was explained just now. Anatomy of the indirect hernia was shown. Note the position of the groin of the hernia neck extending through the internal and external inguinal ring in the panel A. Then in the panel B, the fingers of one hand was first used to sweep along the inguinal canal from the anterior iliac crest to the distal scrotum. The same hand is then used to grasp the testis, hernia mass or scrotal skin and apply gentle pressure. And the panel C, the index finger and thumb of the opposite hand are used to apply upward and lateral traction over the hernia neck to help in keeping the internal and external inguinal rings open. In the panel D, the fingers of the hand on the scrotum are then used to walk the bottom of the hernia sac progressively up towards the inguinal ring until the hernia is reduced. This is actually two-hand method. If the above steps are not successful, the surgeon should be consulted. Most authorities would then recommend sedation with a narcotic drug like morphine, trundle and position, ice pack to the groin, followed by another attempt at manual reduction. Up to 40 minutes of continuous pressure may be necessary to achieve reduction. Attempts at manual reduction of a prolapsed ovary are painful, should be performed only with sedation. In addition, torsion of the ovary within the hernia sac can occur. The timing of repair after reduction of hernia is discussed below. Now, the surgical reduction. In the small percentage of cases where manual reduction is not successful, the hernia must be reduced surgically. Repair is generally performed at that time. Small observational series has described success using a laparoscopic approach for the reduction and repair of the incarcerated inguinal hernia in children. Surgical repair. Following repairing procedures has been used for repair of the inguinal hernia in children. What are they? High ligation and excision of the process vaginalis, the most common procedure, is used when the hernia is small and of recent onset. In girls, confirmation that the hernia sac does not contain ovary, fallopian tube or uterus is necessary before it is ligated. Then, in addition to ligation and excision, plication of the floor of the inguinal canal, that is a transversalis fascia, may be necessary when the inguinal ring has been enlarged by repetitive herniation. To know the anatomy of the inguinal hernia, please consult the video number 1 of this series. Then complete reconstruction of the floor of the inguinal canal using the conjoined tendon is occasionally required in small infants who have large hernias that have gone untreated, causing progressive enlargement of the inguinal ring and total breakdown of transversalis fascia. Laparoscopic herniorrhaphy has been performed for many patients with good results. Boys who have an associated undescended testis should have orchidopexy at the same time as inguinal hernia repair. Timing of repair. Although the methods of repair are standard, the optimum timing is debatable. Immediate surgical repair after successful manual reduction of incarceration eliminates the risk of reincarceration. However, if performed immediately, the repair can be technically difficult, increasing the risk for development of a direct hernia as a complication. In addition, tissue swelling after incarceration can cause distortion of the anatomic landmark, rendering detection of coincident direct hernia difficult. On the other hand, a delay in definitive repair carries the risk of recurrent incarceration and the need for emergent surgery. Risk of recurrent incarceration is between 16 and 35%, with the second episode occurring at a range of 0.5 to 120 days after the initial incarceration. Many pediatric surgeons hospitalize children after successful manual reduction of the incarcerated inguinal hernia, repair the hernia within 24 to 48 hours. The short delay allows the involved tissues to return to the normal texture before surgery. To minimize the risk of recurrence, definitive hernia repair should be performed within 5 days. Within 2 days for infants born prematurely, within 5 days of the manual reduction. So as soon as possible, it is to be done. In children with symptomatic inguinal hernia, longer waiting time for elective surgery is also associated with increased risk for incarceration, especially in infants less than 1 year of age. An observational study from Canada found that waiting time for surgery that exceeded 14 days from the time of diagnosis in a physician's office was associated with an absolute increase of 7%, that is 5 versus 12, in the occurrence of incarceration in infants and young children less than 1 year of age. This finding suggests that a waiting time less than 14 days is advisable for asymptomatic inguinal hernia in this pediatric age group. Approximately one-third of preterm infants with birth weight less than 1000 have inguinal hernia. Those infants can be observed in the neonatal intensive care unit as long as hernias are reducible. The hernias may be repaired before discharge from the intensive care unit once the infants weigh more than 1800 to 2000 grams. Preterm infants who are at risk for apnea and bradycardia should be monitored closely in the postoperative period. Contralateral exploration. The need for contralateral inguinal exploration also is controversial. The natural history of a patent process vaginalis is closure within 2 months after birth in 40% and within 2 years in an additional 20%. Of the remaining 40%, clinical hernias may develop in one half. So, the finding of a patent process vaginalis in the absence of clinical hernia is not a clear indication for future hernia. Although routine contralateral exploration had been a common practice, surveys of members of American Academy Pediatric Section of Surgery conducted in 1993 to 2003 noted that number of respondents who routinely explore the contralateral groin of boys less than 2 years of age declined from 65 to 44%. Similarly, routine contralateral exploration for girls less than 4 years dropped from 84 to 47%. This decline in routine contralateral exploration is supported by data from large prospective studies and meta-analysis of children with unilateral inguinal hernia that identify an overall risk of metachronous hernia between 5 and 12%. These reports all concluded that the low incidence of contralateral hernia did not justify routine exploration. One report noted that the risk of metachronous hernia was higher in premature infants 15% than those with incarceration 28%, suggested that contralateral exploration may be advisable in these children. Also, children at particular risk for metachronous inguinal hernia, including those with the ventriculoperitoneal shunt, increased intra-abdominal pressure, connective tissue disease, or chronic pulmonary disease, should always undergo contralateral exploration, as should those who have an underlying medical condition that increases the risk of anesthetic complications. Thus, the risk and benefit of open contralateral exploration for each child must be weighed individually. The risk of open contralateral exploration should include damage to the spermatic cord, testes and vas difference in boys, damage to the ovary in girls. Benefit of contralateral exploration and repair of the patent process vaginalis as diverticulum of neck is the elimination of risk of future incarceration and need for subsequent surgery. Transinguinal laparoscopic evaluation of the contralateral side during ipsilateral repair has been suggested as an alternative to open surgical exploration and leads to successful visualization of the contralateral inguinal ring in up to 97% of the patients. This technique has a sensitivity 99.4%, specificity 99.5% for detecting a patent process vaginalis and can be performed with a mean operative time of 6 to 8 minutes with a complication rate under 1%. Postoperative care. Most children who undergo repair of inguinal hernia have an uncomplicated postoperative course. Scrotal edema can occur as a postoperative complication. It usually resolves spontaneously over approximately 3 weeks. Postoperative hematoma and hydrocele, on the other hand, can take up to 3 months to resolve and should be followed to resolution by operating surgeon. Postoperative infection occurs with a frequency of less than 1%. Complications. Bowel infarction as a result of strangulation is the most serious complication of inguinal hernia. Infarction may occur within 2 hours of incarceration. Despite the fact that incarceration is not uncommon, particularly in young infants, need for intestinal resection is rare. Incarceration of an inguinal hernia can compromise the blood supply to the testis, resulting in ischemic necrosis and atrophy. Incidence of testicular atrophy from 2 to 9% have been reported after emergent operative reduction of incarceration. Boys with inguinal hernia also can have injury to the vas deferens with the development of spermic agglutinating antibodies. In girls with incarcerated inguinal hernia, torsion rather than direct compression compromises the blood supply to the ovary. Strangulation is reported to occur in between 2 and 33% of girls with inguinal hernia with an irreducible ovary. Because torsion can occur in an irreducible ovary while awaiting elective inguinal hernia repair, some surgeons recommend immediate reduction and repair. After surgical repair of an inguinal hernia, risk of recurrence ranging up to 6%, occurring at various times after the initial repair exists. Risk factors are associated with the recurrence include elevated intra-abdominal pressure like ventricular pectoral shunt, cystic fibrosis and ascites, malnutrition, prematurity, arrested testicular descent, connective tissue disorder, and history of incarceration. So, to summarize, and what are the recommendations we should give? An inguinal hernia develops when the process of vaginalis failed to obliterate during the late gestation, allowing communication between the abdominal cavity and the inguinal canal to persist. Abdominal contents can then herniate into the inguinal canal, and the vast majority of the hernias in children are indirect, with contents protruding through the internal inguinal ring into the inguinal canal. Inguinal hernias in children generally present in the first year of life as an intermittent reducible inguinal mass. The diagnosis may be made by history alone without the presence of a mass on physical examination. Between 14 and 31% of cases, this will be a hernia. The management of inguinal hernia ultimately requires surgical repair. Incarcerated hernia must be emergently reduced. The presence of swelling is not needed to make a diagnosis of inguinal hernia, only the history is needed. Children with a compatible history and those with a reducible mass should be referred to surgeon for evaluation. Because incarceration can occur in children awaiting elective repair, particularly in those less than 1 year of age, we suggest that repair be performed soon after diagnosis, and the recommendation is grade 2B as per the evidence-based medicine. Hope that you know the grading of evidences. We recommend that manual reduction will be attempted for children with incarceration without signs of peritoneal irritation, grade 1B. Immediate referral to a surgeon is recommended if manual reduction is not successful. Children with an incarcerated hernia should have nothing by mouth. In case emergent, surgical reduction is required. Following successful manual reduction of an incarcerated inguinal hernia, children should be referred to surgeon. We suggest that definite hernia repair be performed within 5 days, within 2 days for infants born prematurely after the reduction. The recommendation is grade 2B. I thank profusely and acknowledge all the following references for giving me a chance to prepare this concept bridge. This video session is exclusively meant for medical students and faculty. The email address, the YouTube channel address and Facebook channel address are given. And these are the references. Hope that session was useful to you, and the next will be concept bridge in obstetrics and gynecology on intrapartum fever. Goodbye from ACPGMed. Please visit the channel youtube.com/ACPGMed. Thank you.